All right, then let's begin today's class. We'll start and complete the GID. Voice is clear. Sushi, voice clear है? All right. Sushi, is my voice clear? Audible? Hello, मेरी आवाज आ रही है? Okay. So let's begin. We have first GIT embryology. Today we'll try to finish GIT entirely. It's a big system, so it might take a little long time. So let's just finish and let's just start. So first one, GIT embryology. We have the first normal embryology. Okay, so in embryology, you just have to remember foregut developed from where, midgut developed from where, hindgut developed from where. That's it. Nothing else you need to remember. They won't be asking much question regarding this. In embryology part, what they will be focusing on was on gastroschisis and omphalocele. So they will be focusing more on the ventral wall defect. Okay, so let's just see what you need to remember here. The developmental defect due to failure of rostral fold closure. Okay, they will give you diagnosis of gastroschisis or omphalocele, and then they will ask you which fold closure: ventral fold closure, caudal fold closure, rostral fold closure. All those type of fold closure they will be telling, and you need to figure out what type of fold closure they are talking about. Okay, so you have rostral fold closure, example sternal defect, ectopia cordis; lateral fold closure, example omphalocele, gastroschisis; and caudal fold closure, that is bladder extrophy. So for omphalocele and gastroschisis, you have lateral fold closure. Okay, so any of them you can select. So let's see the presentation and distinguishes between gastroschisis and omphalocele. We have exclusion of abdominal contents through abdominal wall defect, herniation of abdominal contents through umbilical. In gastroschisis, it is not covered by peritoneum or amnion. It is covered by peritoneum and amnion. Association, not associated with chromosome abnormalities, associated with chromosome abnormalities. So these 3 points are important. Not covered by peritoneum or amnion, covered by peritoneum and amnion. Second, not associated with chromosomal abnormalities and associated with congenital abnormality. Okay, so this is important that you need to remember. Coming to congenital umbilical hernia, it is a failure of umbilical ring to close after physiologic herniation of midgut. Okay, this is one important line. Covered by skin, protrudes with intra-abdominal pressure, may be associated with congenital disorders. Okay, so this is not very important, but in one question they asked in NBME, and it was umbilical ring closed, failed to close after physiologic herniation of midgut. So this line was important, and then gastroschisis and omphalocele are very high yield. At least they will confuse you, and you just have to pick out whether it is covered or not covered. Okay, so that is important over here. Moving ahead, we have TEF abnormality, tracheoesophageal abnormalities or anomalies, whatever you want to call. The most common one being is this one, EA with distal TEF, EA with distal TEF. What does it mean? Esophageal atresia with distal tracheoesophageal fistula. Okay, so this one is very common. They will be asking about this only. They won't ask about any other thing. Okay, so let's just see what happens over here, what all conditions they will be giving you in the exam. The first one is that they will give you is the neonates drool, choke and vomit with first feeding. Okay, as soon as they go for the first feeding, that is mother's milk, breastfeeding में जो पहला होता है, and as soon as they take it, the neonate will drool and choke. Okay, and the neonate will vomit out. Okay, because क्या होता है कि esophageal atresia है and there is a fistula with trachea. So there is no connection going down. The food won't be going down after consuming it. Okay, so it will be there only in the esophagus, and due to reflux, due to pharyngeal reflex, it will be coming up. Okay, so TEF allow air to enter stomach visible on chest X-ray. Okay, so in the question they will say air is visible clearly. And the next thing that will help you to confirm this diagnosis is failure to pass nasogastric tube in stomach. They will pass the nasogastric tube. The tube will be passed to the neonate from the nose, and then it won't go into the stomach. It will be stopped over here. So that tube you will be seeing that on the X-ray. If tube is going all the way down to stomach, this is not a diagnosis. If it is not going down the stomach, if it is stuck over in this part, then it is TEF. Okay. So these 3 points they will definitely give: drool, choke, vomit, air, and failure to pass nasogastric tube into stomach. Okay, so you just need to remember this. And what is the pure one? One important point in the pure esophageal atresia, CXR shows gasless abdomen. So this is see, this is your pure esophageal atresia, and here there will be gasless stomach. Okay, but in TEF with EA, gas has to be present, and this is symptom they will definitely give. Moving on to intestinal atresia. Intestinal atresia becomes one of the very high yield. Okay, the first one why it becomes very high yield, it is associated with Down syndrome. Duodenal atresia is associated with Down syndrome. Okay, so this becomes very important. Let's just see what is present over here. Presence with bilious vomiting. So it means there will be bile components in the vomit, along with abdominal distension within the first 1 to 2 days of life. This is very important. So along with bilious vomiting, this 1 to 2 days of life is very important. Okay, these two things are very important. Okay. And next one. So let's just see what are the two types of atresia: duodenal atresia and jejunal and ileal atresia. Most commonly, they will be asking you about duodenal atresia. Okay. Let's just see failure to recanalize. This is the mechanism. Failure to recanalize. X-ray shows double bubble sign. Double bubble. Okay. And associated with Down syndrome. So all these 3 points are very, very important. You should keep this in mind. If there is a duodenal atresia, the first thing they will ask is, instead of directly asking the diagnosis, they will ask you what else is going here. So you will say there is a failure to recanalize. Okay, this is the first point. Second, it shows double bubble sign. Okay, double bubble sign is seen in duodenal atresia. And next, it is associated with Down syndrome. I already told. So this is what about the duodenal atresia. But along with that, they will be saying bilious vomiting and first 1 to 2 days of life. This all these points are very important. Directly, they will give you the question. Okay, it's a direct diagnosis, easy diagnosis. Coming to jejunal and ileal atresia, what happens over here is there is a disruption of mesenteric vessels, especially SMA. So there is ischemic necrosis of intestine, segmental resorption. So if they give you anything related to the SMA, okay, and along with that they give you bilious vomiting and it occurs within the first 1 to 2 days of life, straight away go for jejunal and ileal atresia. Okay. Another thing, how you can differentiate duodenal and jejunal ileal is X-ray may show triple bubble sign. In duodenal, double bubble, whereas in jejunal and ileal, it will show triple bubble. Okay. And gasless colon associated with cystic fibrosis may be caused by maternal cigarette smoking. This is not necessary. So 3 points what you need to remember in intestinal atresia: bilious vomiting, first 1 to 2 days of life. If it is duodenal, it has to be failure of recanalization, and if it is jejunal ileal, it has to be because of some necrosis in the superior mesenteric artery. Double bubble in duodenal, triple bubble in jejunal ileal. Okay, that's it. Now coming to hypertrophic pyloric stenosis. Now, sometimes what happens is the diagnosis will be confused between intestinal atresia and pyloric stenosis. Now, how to distinguish between them is just look at the vomiting. Here, there is a non-bilious vomiting. It means that the bile components won't be present in the vomit. Okay, no bile components in the vomit. Whereas in intestinal atresia, bile components will be present in the vomit. Okay, so like this, you have to differentiate. Another thing, it occurs as 2 to 6 weeks old, whereas intestinal atresia occurs at first 1 to 2 days of life. 1 to 2 days, 2 to 6 weeks. So this is how you will differentiate. If sometimes what happened, the symptoms are not able to differentiate. Okay, so this is how you can differentiate. Another thing, palpable olive-shaped mass in epigastric region. This is the for sure diagnosis of hypertrophic pyloric stenosis for your diagnosis. Okay, so let's just see another things that are important. Results in hypokalemic, hypochloremic metabolic alkalosis. They will ask you what will happen. So decrease in potassium, decrease in chlorine, and metabolic alkalosis. So this is very important. Okay, this is very important along with all these features. This can occur along with macrolides. I think one question was there in the NBME. Only one question in the entire all the mock test. Okay. So ultrasound shows thicken and lengthen pylorus, and the treatment is pyloromyotomy. Okay, so this is how you will be distinguishing pyloric stenosis and intestinal atresia. Both are very high yield questions are going to be come for you. Okay, so that's it. Let's move forward. Pancreas and spleen in embryology. Two disorders of pancreas are there: annular pancreas and pancreas division. So before that, let's just see one thing. The spleen, it arises in the mesentery of stomach, hence it's mesodermal, but has foregut supply. Okay, mesentery में develop है but foregut supply है. Okay, and let's just see annular and pancreas division. Annular pancreas, abnormal rotation of ventral pancreatic bud, whereas pancreatic division is ventral and dorsal part fail to fuse at 7 weeks of development. This is a mechanism that you need to remember. What is actually happening? Okay, so here what will happen? Forms a ring of pancreatic tissue and circles second part of duodenum. Second part of duodenum will be encircled over here. Okay, so see, ये duodenum है और इधर आजू बाजू pancreas पूरा encircle कर रहा है. So this is what the X-ray is. They won't be asking you about this, but the radiological images are not asked in pancreas and spleen embryology at this level. So just focus on the information. Abnormal rotation of ventral pancreatic bud, pancreatic tissue encircles the second part of duodenum, may cause duodenal narrowing and vomiting associated with Down syndrome. So as here it is duodenal vomiting. Duodenal vomiting hai, so it will be bilious vomiting. Okay, don't get confused. Here also bilious vomiting, in duodenal atresia also bilious vomiting, but there will be no double bubble sign here. Okay, so this is how you will be distinguish. One small features are very important to distinguish different types of condition. Okay, moving on to pancreas division. Common anomaly, mostly asymptomatic, but may cause chronic abdominal pain or pancreatitis. Okay, that's it. बस आपको mechanism याद रखना है. What actually happens at what? Okay. That's it for embryology. Now let's focus on the anatomy. GIT is a system where you have to focus more on anatomy. Okay, just give me a minute. All right, let's start with GIT anatomy. So in anatomy, this retroparietal structures, you have to remember them. Okay, you have to remember them. There is nothing. There is nothing we can do. Okay, so just remember what this mnemonic, and you will be good to go. And they will definitely give you in the question if they want to ask you about the retroperitoneal injury or retroperitoneal organ damage. They will definitely give you in the question. You don't have to apply so much brain, and this is actually the main part of step 2 CK. They won't ask on step 1 more. So just remember the organs over here. The organs they will be asking you, and this CT scan, CT image of abdomen is very important. They will be asking you to identify the organ. Okay, so you should be able to identify whatever they ask you. Okay, in the exam they will give you A, B, C, D, E, and all those stuff. So you should have a practice about it. Solve more and more questions about it. Okay, just remember this by the mnemonic. Ligaments you can actually ignore. There is no need to remember the ligaments and everything. Just one stuff you need to remember. Yeah, that's all you can ignore. Everything you can ignore. Okay. The one thing that you need to remember here is hepatoduodenal ligament. Hepatoduodenal ligament is important, and why it is important? Because here the portal triad will be present beneath the ligament, and Pringle manure. Pringle manure, they will give you in the question the Pringle manure, and they will explain you what is happening with the Pringle manure. Okay, they will say he the surgeon inserted two fingers to stop the bleeding. Now, what they will ask is, they will ask ki bleeding from which artery will be stopped. Okay, so bleeding from which artery will be stopped? So that is bleeding from hepatic vein or hepatic artery will be stopped. Okay, foramen to control bleeding from hepatic inflow source, portal vein, hepatic artery. Okay, so hepatic artery से bleeding रुक जाएगी, but the bleeding won't stop from IVC or hepatic vein. Okay, so this is the distinguish to know whether the bleeding is occurring in the abdomen from IVC or because of hepatic artery. Okay, so Pringle maneuver is very important and they will ask you कि Pringle maneuver का location कौन से ligament पे आएगा, so that will be hepatoduodenal ligament. This question is there in the UL also. Okay, so I hope you know it. Okay, that's it. Rest all ligament you can ignore. No questions have been asked. Coming to the digestive tract anatomy and histology. Histology is also very important. So let's just have a quick review over here. Mucosa, submucosa, muscular rejection, and serosa. Now you know there are some structures like esophagus and gallbladder. Esophagus might not be having one or two structures. Gallbladder might not be having one or two structures. So uh, going to that detail is not necessary over here. What is necessary here? Let's just see. Mucosa, submucosa. Submucosa has now plexus Meissner. Meissner now plexus secretes fluid. Muscularis externa has meandric now plexus, and that is for motility. This is important. Serosa adventitia. So serosa when intraperitoneal, adventitia when retroperitoneal. Retroperitoneal we saw the organs that you need to remember the mnemonic. Now ulcers can extend into submucosa, inner or outer muscular layers, but erosions are only in mucosa. Okay, they will ask you which of the following is the correct. Okay, they will ask you questions like this here also. So you should know erosions and ulcers ka definition kya hai and where they occur. Okay, they will twist the points over here. Moving on to the frequency of basal electric rhythm, which originates in the interstitial cells of Cahill, duodenum, ileum, and stomach. Okay, so this is the speed. The subsequently strongest in duodenum, ileum, and then in stomach. Okay. Now, one more thing I want you to remember here is the histology part. In the histology, you should be knowing key what structures are present where. Okay. For example, in the esophagus, like what we have is, yeah, striated muscle in the upper one third, whereas middle and lower one third has smooth muscle. Okay, this is very very high yield. This is very, ignorable stuff. You must have ignored this, or you must have not studied properly, but the questions are frequently asked over here. So let's just see. Normally it is non-keratinized stratified squamous epithelium. Okay, epithelium का type भी आपको याद रखने हैं. Stomach, parietal cells are eosinophilic, that is pink. Chief cells are basophilic. Okay, so just see the in the image, pink and basophilic. Coming to duodenum, villi and microvilli increase in absorptive surface. This is important. Brunner glands, bicarbonate secreting cells of submucosa, important. Crypts of Libercun, important. And plica circularis, important. Jejunum, villi with crypts of Libercun, plica circularis. Taller, more prominent and numerous. Flattered appearance with oral contrast and increasing surface area. This was the question asked in NBME. What they did was they didn't give the information. Instead, they gave sorry, they gave a barium study, and in the barium study, how they gave it, we like see at this level we are not able to, and we are not expert to know whether it is duodenum or jejunum that they are showing on the chest scan. Sorry, on the X-ray. Okay, so what they did was they gave the question, and in that they gave this duodenum part, and in when it came towards the duodenum part, the contrast that was given, that the enema or the barium enema, I actually don't remember the question, the enema that they gave, the contrast that they gave, they showed this appearance, and they said this is X and this is Y, and they didn't ask directly whether it was jejunum or duodenum. What they did is they gave that this structure contains the feather appearance with oral contrast with villi, crypts of Libercun, and plica circularis. So this feather appearance isn't there in duodenum, but it is there in jejunum. Okay, and this feather appearance was easily visible on the X-ray or the whatever they gave. Okay, so this is very important. This is how you will be tricking you. Okay, so you should remember this information. So this small information will help you to distinguish between the answers. Okay, coming to ileum, villi, pair patches, plaque circularis, crypts of lubricant, largest number of goblet cells in small intestine. And here colon crypts of livercun with abundant goblet cell but no villi. If they say no villi, think about they are talking about colon. So this I'll tell you extremely high yield. Very basic questions might be asked from here. Okay. And this was a question asked in NBME, and it was the first question in any one of the blocks. Okay, so if you have solved it, you must have encountered this question for sure. I've done this question wrong, that's why I know it properly. All right. Moving ahead, abdominal aorta and branches. Yes, they ask about the abdominal aorta and branches here. So in this, they have just given the diagram. They haven't explained anything. So if you have your anatomy notes that is studied in NBMS, just give it a read over there. Okay, all the important regarding abdominal aorta and branches and everything. Okay, so let's just see what is important over here. From where does the IMA branch off? From where does the HMA branch off? What is the level of celiac artery? Then what is from where does the bifurcation occur of aortic aorta? Okay, this all are the common questions that they will be asking you. Then they will be asking you about the watershed areas, the splenic flexure and rectosigmoid junction, SMA, IMA, and IMA superior rectal artery. So watershed areas they will be asking you the question for sure. And yeah, these two symptoms, nutcracker syndrome and superior mesenteric artery syndrome. Okay, don't go into detail over here. Just remember one or two lines because in surgery, the part of surgery and part of step to CK, and there so many questions are there. How to diagnose, how you will treat, how you will manage. So many questions are there. No need to go in such a detail over here. Just look, nutcracker syndrome, compression of left renal vein between superior mesenteric artery and aorta. That's it. That's it. What you need to remember. Okay, that's it. Coming to superior mesenteric artery syndrome, characterized by intermittent intestinal obstruction syndrome when SMA and aorta compress transverse portion of duodenum. Third portion of duodenum is compressed over here, whereas here the renal vein is compressed. Okay, now here in this superior mesenteric artery syndrome, they will typically give a very thin patient. Okay, thin patient है, so fat won't be there. So if there is no fat, there is no cushion for the third part of duodenum, or else it will be wrapped around the superior mesenteric artery. Okay, this is what happens over here. So this two, just the one line, and in SMA syndrome you just need to remember the case. Thin patient will be given. Okay. Yeah, one more thing I would like to tell you. uh, Refer your old anatomy notes over here and learn about SMA and IMA branches. Okay, I'll write it down in a short form for you. So, but you need to see your own notes because these are my notes. You might not understand or you might not sure about these notes. But let's just see what I wrote in my first aid. Ileocolic, right colic, middle colic, and here is ileal and inguinal. So these, no, sorry, not inguinal, jejunal. So you can write it down. If you don't have your notes with you, you can write this down. And for ileocolic, it will supply ileum and ascending colon. Right colic will supply just the ascending colon because it is present on the right side. Middle colic will supply the transverse colon. Okay. Now coming to the IMA branches, and why I am asking you this is because uh, they will ask you that the right side of the colon was disturbed, which arterial supply will be affected over here, or the right side of the arterial supply in the colon region is disturbed. So, what part of the intestinal duodenum will be, will get necrosis or disturbed over here? So, like this, they will be asking you. So, anatomy is very important when you study GIT. So, let's just see about the IMA, inferior mesenteric artery syndrome. So, you have three divisions here as well. First one is left colic. Second one is superior rectal artery. Third one is sigmoidal artery. Okay. So what happens here? They will be supplying the descending colon. Superior rectal will supply the upper rectum. Sigmoidal will be supplying the sigmoid colon. Okay. And one more branch you need to be aware about, internal iliac artery. So internal iliac, they have two. That is, first one is middle rectal and second one is pudendal. So pudendal will be supplying inferior rectal. Pudendal will be giving a branch of inferior rectal. Okay. So this is the anatomy part. You can note this down, or else you can refer your own anatomy note that you studied during your med school. So if you want to write it down, I'll give you 2 minutes. Just write it down. This is very important. They will ask you question regarding anatomy. Okay. Right. Let's move ahead. Gastrointestinal blood supply and innervation. Again, foregut, midgut, hindgut, celiac, SMA, and IMA. Okay. One thing we need to do that. Okay, that's it. So this celiac trunk, the branches of celiac trunk, they have not given so clear over here. Okay, so I would highly recommend you to please refer your anatomy note. Furthermore, if you want to write down my division, just copy what I am writing it. So celiac trunk, we have three branches. First one, left gastric, splenic, common hepatic. Okay, so now this common hepatic will be having other three branches. First one, proper hepatic. Then you have gastroduodenal. They have two branches only. Okay. Now moving on to splenic, they have two branches. Short gastric, and next one is left gastroepiploic. Okay. Now left gastric will give to esophageal arteries. Okay, celiac trunk is very important, guys. They will ask you the question. So many questions. Okay, so be sure celiac trunk is very important and high yield. Now another thing, going ahead, proper hepatic will give into three branches. One, two, three. The first one will be cystic artery. Second one, it will branch into right and left hepatic arteries. And the third one will be right gastric artery. Okay. And gastroduodenal will be giving out into anterior superior and posterior superior, and both of them will be doing pancreatico duodenal artery. Okay. And another thing gastroduodenal will be giving is right gastroepiploic. Okay, so whatever is written in green in this, cystic artery is important and right and leg hepatic artery is important. Rest all you can avoid the green one. But whatever is written in black, red, and blue, they are very important. So if you are not able to understand this flowchart or this division, refer your own notes and select run is very important. Questions are going to become. Okay, this is the GIT anatomy. They ask so many questions. Okay, so you have to be prepared. All right, write this down. All right, moving ahead, we have portosystemic anastomosis. Now, this is also part of surgery. In step 2 CK, they will ask you in more detail, but here you have to focus on just where the shunt can be created. Okay, left gastric artery, esophageal artery. Okay, umbilicus में paraumbilical to small epigastric vein. Rectum में superior rectal and middle and inferior rectal. And for fourth one, okay, they haven't given the okay, these three are only there. Okay, so see, this is what they are talking about when there is a portal hypertension or cirrhosis or some other conditions are there. We go for TIP procedure, and before TIP procedure, these all are the anastomosis that we will be seeing. Okay, so in case of portal hypertension or cirrhosis, all these types of anastomosis, they are clearly visible. Okay, so you should just be clear, and the question they will be giving you about the portal hypertension or else cirrhosis they will give you. Okay, and based on that they will ask you, there were the so many cutaneous veins were seen around the umbilicus, so what is the anastomosis of the which anastomosis is occurring over here, like this they will be asking you. Okay, so treatment with tips between the portal vein and hepatic vein. Okay, portal vein and hepatic vein, this is important. That's it, portal vein and hepatic vein, and they can relieve portal hypertension. As I told you, portal hypertension का ही question आएगा. All right. Now this, as I already mentioned above, very important and very confusing, and you will be forgetting it again and again. Okay, I मेरे साथ तो होता था. I don't know about you. So let's just see how it is important. You need to remember the nerves, arteries, veins, lymphatic nerves, arteries, veins, lymphatic above and below the pectinate line. Okay, above the pectinate line, internal hemorrhoid, adenocarcinoma. Below the pectinate line, external hemorrhoid, squamous cell carcinoma. Even the anal fissures will be occurring under external carcinoma. Sorry, below pectinate line. Okay. Now, what other things? These are not painful. These are painful. And another thing is, yeah, that's it. Internal adenocarcinoma, not painful. External anal fissures, commercial carcinoma, painful. And all these nerves and this supply, these are very important. The most commonly they will be asking you about the lymphatic, internal iliac lymph node, superficial inguinal lymph node. Don't confuse yourself. Okay. So this is the entire page I'm telling, very important. This new topic they have added here in 2022 edition. It wasn't there in 2020, but the question was there in this UL. That's why they added. So tear in the anoderm below pectinate line, pain while pooping, blood on toilet paper located in the posterior midline because this area is poorly perfused. Okay, associated with low fiber diets and constipation. So this is important. Low fiber diets and constipation is important, and pain while pooping and blood on toilet paper. The 3 points will be given if they want to talk about the anal fissures. Okay, so this is very high yield. This page, just mark it. All right, moving to the liver. In the liver, what all you need to remember is the functional unit of liver is made up of hexagonally arranged lobules. Okay, and portal triage में क्या क्या आएगा? Portal vein, hepatic artery, and bile duct. And what else you need to remember is, yeah, this small information they gave me in the exam. It wasn't there. This question wasn't asked in the UL, but I think NBME had it. And in the exam also they asked me. Apical surface of hepatocyte faces bile caniculi. Basolateral surface faces sinusoid. Okay, they asked this question. So this is become high yield. Kupffer cells located in sinusoid. They clear bacteria and damage or senescent RBC. So Kupffer cells are specialized macrophages. Okay. Now one very high yield point is hepatic stellate cells in the space of these store vitamin A. and produce extracellular matrix that is responsible for hepatic fibrosis. Very, very high yield. When question will be asked, he scars were seen on the biopsy, fibrosis was seen. Okay, if they say fibrosis was seen or the scars were seen, you should think about लीवर में हेपेटिक फाइब्रोसिस हुआ है बट व्हाट सेल्स विल बी कॉजिंग द हेपेटिक फाइब्रोसिस द आंसर इज stellate cells, hepatic stellate cell. This is very important. Two times NBME had asked this, and even you will have asked this one. Okay, so you should know this. Very important. Okay, now coming to zone 1, zone 2, and zone 3. In zone 1, remember viral hepatitis. In zone 2, you need to remember yellow fever. And in zone 3, first affected by ischemia. Remember the names also pericentral, intermediate, and periportal. You will have it. Okay, you will have the question. So you have to do it. And all the metabolic toxins zone 3 में problem होती है. Alcoholic hepatitis भी zone 3 में होती है. So this entire page becomes again very high yield. This is all about the basic information. Okay, this is basic information. So with this, we are done with liver tissue and architecture. Biliary structures, they haven't asked so much over here, but one important point you can learn here is tumors that arise in the head of pancreas. They are usually ductal adenocarcinoma, can cause obstruction of common bile duct, enlarged gallbladder with painless jaundice. This is important. So they might ask you the cancer in pancreas head. And in the options, they will give you adenocarcinoma, squamous cell carcinoma, transitional carcinoma, all those stuff. So you should remember ductal carcinoma, adenocarcinoma is very important. And what else is important over here? Okay, that's it. So with this, we are done with the GIT part. Okay, GIT part can anatomy we are done. Now all those stuff will be focusing on hernia. Hernia, they don't ask so many questions. Like one question they might ask, and that was regarding the indirect, direct, and femoral hernia. They haven't asked any question regarding femoral triangle, femoral sheath, femoral region. Okay, so I'm not saying they won't ask. Just give it a read. Okay, just give it a read. In the NBME also there was no question. I think one question might be there, but in the UL they haven't asked what are the constituents of femoral triangle or femoral sheath or femoral canal. Nothing like that they have asked. Okay, so let's just move. Yeah, one thing they have asked is lateral to medial, the arrangement of nerve, artery, and limb. They have asked this. Okay, so make sure you know only this much. That's all you can avoid. Even in the inguinal canal, what they have asked is, I'll write down for you. Just remember that part. I'm writing it down. So just copy it. Inguinal ligament is a remnant of external oblique aponeurosis. Okay. Anterior, posterior, and roof of inguinal canal, internal oblique. Transverse abdominis, lateral wall. That is roof and posterior wall of inguinal canal. And last one is transversalis fascia. What does it form is roof. Okay, so this is high yield because they have asked questions regarding the boundaries of inguinal canal, but they haven't asked any question regarding the femoral canal and everything. Another important point that I want you to remember here is this: internal spermatic fascia is of transversalis fascia. Cremasteric muscle and fascia is because of internal oblique. External spermatic fascia is external oblique. Okay, and another thing that I wanted to know is Yeah, for now only this much remember. If I remember, I'll let you know. Yeah, this is conjoint tendon. You can see conjoint tendon over here. It is the combination of these two, internal oblique and transversus abdominis muscle. So transversus abdominis plus internal oblique. Okay, so this is important. These all the points that I have made you write it down. These are from UWorld. Okay, they have asked the question, and in NBME also one or two questions have been asked. So this becomes important. This is important. Remember, if you don't understand anything here, the best way is go back to your notes and refer. All right, now coming towards the different types of hernia that they like to ask. Very simple, don't have to focus more over here. So let's just see. For leave diaphragmatic hernia for now. First, let's just continue with indirect and direct. Okay. So in indirect, go to the internal and external into the groin, enters internal inguinal ring lateral to the inferior epigastric vessel. Lateral to the inferior epigastric vessel. Okay, this is important. Caused by the failure of processes vaginalis to close. Okay, and that's it. So these 2 points, yeah, may be noticed in infants or discovered in adulthood, much more common in males. So all these points that I told you, they are all these points will be given in the question. Okay, you don't have to find out what type of hernia they're talking about. In the if they want to ask you about indirect, you have to remember the lateral to the inferior epigastric vessel. It passes to both internal and external, that is deep and superficial ring. That is caused by the failure of processes vaginalis to close and much more common in males. Okay, these are all the points that are important for indirect. Coming to direct, protrudes to the inguinal, that is Hasselbeck triangle, bulges directly to the parietal perineum, medial to the inferior epigastric vessel. Medial. In indirect, it is lateral. Indirect, it is medial. Goes to the external. Deep won't be there. It won't go to the deep one. It will only go to the superficial ring. Okay, so this is important and usually occurs in older males due to acquired weakness of transversalis fascia. Okay, so these 3 points are important. And if you are confused, कि medial to inferior epigastric is in direct or lateral to inferior epigastric is in inguinal, sorry, indirect. Remember this mnemonic: MD don't lie. So medial to inferior epigastric, direct, MD. Lateral to inferior epigastric, indirect, LI. Okay, so this is very very important. You need to remember. Coming to the femoral hernia. So in femoral hernia, protrudes below the inguinal ligament through femoral canal. Okay, much more common in females, and it can be present with incarceration and strangulation. Strangulation means instead of strangulation they will give you ischemic necrosis. Ischemic necrosis of intestinal segment. Okay, and incarceration is I think it can't be reduced back. Yeah, yeah, can't be reduced back. Okay, so femoral, if they are talking about females, you need to know femoral hernia. If they are talking about older males, direct hernia. And if they are talking about small children or in adulthood, indirect inguinal hernia. Okay, so these three types they most frequently ask. Now let's just quickly see the diaphragmatic hernia. They don't frequently ask this, but let's just see. If it is in infants, we did this in the respiratory system. Congenital defect of pleuroperitoneal membrane, left-sided herniation. So what will happen? All the intestinal contents will be seen on the chest X-ray. Okay, chest X-ray में आपको intestinal contents दिखेंगे. Adults, laxity or defect of phrenoesophageal membrane, hiatal hernia. So herniation of stomach through esophageal hiatus. Okay, sliding and paraesophageal hernia. So sliding may just remember hourglass and that's it. They won't ask this in detail. If they want to ask you in detail, the one thing they will ask you is congenital diaphragmatic hernia. Okay, and this is we have done in the respiratory system. Okay, so with this we are done with the anatomy part. Now we'll be moving to the physiology part. GIT is very big. Let's see how much we complete in 3 hours. So yeah, that was all about anatomy. Now this page of your physiology, it becomes very important. How? I'll tell you. What they like to ask over here is, see, you have to remember the cells. Okay, you have to remember what cells will secrete what. That is okay, you will remember it. That is easy. Now the another important point with how they will like to confuse you is they will be asking you the effects, the action they will be asking you. Okay, and the most commonly asked question, most commonly asked hormone is cholecystokinin, and here they will be giving you gallbladder contraction is increased or gastric emptying is decreased, sphincter of OD relaxation is increased. Okay, so you know how they will be asking you, they will give you any abnormality or disease of gallbladder. It can be cholecystitis, A calculus cholecystitis. Okay, in A calculus, there is no stone. Okay, there is no stone, but because of stasis or because of impaired blood flow or because of ischemia that is occurring. Okay, so what will happen? The gallbladder won't contract, so decrease in contraction. And which hormone is responsible over here? Cholecystokinin. So this is how they will be asking you. Okay, totally clinically based they will be asking you. They won't ask directly also, so you have to keep your brain open what they are asking about. Okay, so actions in this are very very important. I would highly recommend you go to the actions, very very important, along with the name of cell. Okay, and another important point that you can, if you want, you can remember, is going to be very helpful is how and what is happening here, like how will it increase, how will it decrease. Okay, very important. So this page becomes very high yield. So just know the actions, the cells, and the regulation. Okay, rest all in this extra part you can avoid. I'll cover whatever is there in the extra part later. Okay, so mark my word. Have pay proper attention to the action here. They will ask this question. Most common they will ask is cholecystitis. Okay, so let's just now move towards other locations of gastrointestinal secretory cells. Okay, before that, the gastrointestinal secretory products is also there. Here they won't focus more. So just give a read. Just remember what cells are secreting what. That's it. They won't ask more over here. Whatever they want, they will be focusing in this page only. They won't focus here on this page. Okay, so it's okay. You can avoid it. This is the summary of all the cells they have given. Okay, and pancreatic secretion. In this, what you need to remember is you need to remember how the trypsin is going to activate all other stuff. And if trypsin is going to increase and increase, it might lead to pancreatitis. So all these are the basic stuff. You just give a read. You never know how the questions will be asked, but here they asked one question in the UL. This was the question regarding this information. Isotonic fluid, low flow, high chlorine, high flow, high bicarbonate. So it was the pancreatic secretions may they asked when there is a low flow which ion will dominate, when there is high flow which ion will dominate. They asked this. Okay, so remember this one line and then you're good to go. You have this over here. Fructose is taken up by a facilitated diffusion by GLUT5. All are transported to blood by GLUT2. So yesterday we saw in the insulin part only कि GLUT2 से glucose अंदर आता है. GLUT2. Just be confirmed. I am not sure. I don't remember the glutes. So just remember that. Only monosaccharides, that is glucose, galactose, and fructose, are absorbed by enterocytes. Glucose and galactose are taken by SGLT1. Okay, that is sodium dependent. So remember this. This is important. Okay, so in physiology, they won't ask more into detail except the hormone part. Okay, so just remember the hormone. Vitamin, they will ask you where is iron absorbed? Duodenum. Folate absorbed? Small bowel. B12 absorbed? Terminal ileum. That's it. Okay, and they won't ask directly. They will give you there was surgery, and in that ileum has to be removed. Now, what will be the deficiency? The deficiency is B12 deficiency. Okay, And sometimes what they will ask you, duodenum some part has to be removed, so iron deficiency. Small bowel thoda nikal diya to folate deficiency. So they will be confusing you with giving you the cases, 10 liner case they will be giving you, and you have to figure out. This is what they will be testing your patients in the exam. Okay. Pair patches, don't give such a detail, never ask. Bile, composed of bile salts, bile acids conjugated to glycine or taurine. This is important. Glycine or taurine is important. Making them water soluble, okay, not important. Cholesterol 7 alpha hydroxylase catalyzes the rate limiting step of bile acid synthesis. Okay, this is important over here. Functions you can ignore. And yeah, that's it. So this is all about one liners that they will love to ask. Bilirubin, yeah, this is very important. And why it is important is because in pathology we will be studying some disorders regarding them. Okay, so just remember this, remember the diagram. Okay, remember the diagram, remember this. When what is occurring, this hormone, after that what is occurring, urobilinogen, it will go in fishes, it will go into kidney, everything. Remember this is important. You will be studying about this in while you study the jaundice and all the pediatric disorders like Crigler-Najjar syndrome, the Dubin Johnson syndrome, and all those stuff. Okay, so if you rectify that, well and good. But sometimes you might not be able to remember the information that you have rectified. So you need to be thorough with this diagram. Okay, so I think we are done with the physiology also over here. Now we'll start with the pathology. The most sorry, I got just removed. No problem. My voice is audible now. Pooja, Srishti, just give a thumbs up. All right. So, any doubt in anatomy and physiology till now, Srishti? Any doubt? It's been so long. एक घंटा हो गया, कोई doubt है?
No, so far.
No doubt. Okay, okay. All right. So let's start with our pathology, and the pathology is going to be a very, very big discussion now. Let's just see how much it comes. GIT pathology, one of the most high yield systems, and sometimes it gets boring and difficult. Sometimes, okay, this is not. See, I am being honest. GIT is where if you pick out the symptoms, if you pick out one word from the question, you will be getting 100% diagnosis correct. But sometimes what happens is they twist you with the symptoms, and that's where you get it wrong. Okay, so I won't consider GIT to be very easy, like endo and all those stuff. Okay, so let's just see oral pathology. Not very asked, like salivary gland tumors, they are not asking it very frequently. So in this, what they will be asking you about is aptus ulcers, because aptus ulcers occurs with Crohn disease. Okay, Crohn disease के साथ aptus ulcers होते हैं. So that's why we need to see. ऐसे ही लिखेंगे. Transparent ulcer. Okay, let's just see what they have given. Canker sores, common oral lesions that appear as a painful, shallow, round to oval ulcers covered by yellowish exudate. Recurrent aptus stomatitis associated with celiac disease, IBD, SLE, Behcet, and HIV. IBD is important, celiac disease is important. Okay, aptus ulcer easy to identify. Squamous cell carcinoma most common by HPV, इतना याद रखना है, and tobacco. Okay, nothing else. Leukoplakia and erythroplakia. So leukoplakia में white patch and erythroplakia. Now one important thing they asked it in the BNB they have taught this. कि leukoplakia and you have one more stuff. Yeah, candida infection that they cause. Okay, so how you will distinguish between leukoplakia and candida? So leukoplakia जो होगा ना, you can't excise it, but candida you can excise it. Okay, ऐसे रिमूव कर सकते हो ल्यूको कैंडिडा को, but leukoplekia you can't excise it. Okay, so if leukoplekia is occurring, it means it is involving your entire internal system, immune system. Okay, so that's it. Let's move forward to now salivary gland tumors, pleomorphic adenoma, Martin tumors, mucoepidermal carcinoma. So let's just see what is happening over here. Pleomorphic adenoma most common. Okay, if they ask you most common pleomorphic adenoma, and this line composed of chondromyxoid trauma and epithelium. Chondromyxoid trauma and epithelium is important. See why we are doing this, because in UL they have given one question, but NBME and exam won't ask you about the salivary gland tumor. Okay, coming to Warthin tumor, papillary cystadenoma, lymphomatosome, germinal centers. Okay, germinal centers was given, and people who smoke, then Warthin tumor. And mucoepidermoid, most common malignant, mucinous and squamous component both. So easily identifiable. Pleomorphic में chondromyxoid trauma epithelium दिया रहेगा, Warthin में smoker and germinal centers दिया रहेगा, mucoepidermoid में malignant tumor. So this is how you will be remembering. Coming to echinacea, very first high yield condition. Okay, so let's just see what is given here. Echinacea cardia. The first important line is failure of LES to relax due to degeneration of inhibitory neurons containing NO and VIP in the myenteric plexus of esophageal wall. So each and every point that is containing NO, VIP, inhibitory neuron, failure of LES to relax in the myenteric plexus, each and every word is very important. Okay. Second, it is presenting with dysphagia to solid and liquid. Okay, and the first thing that will be obstructed here is liquid first. Okay, liquid first, then solid. So this is very important. And what do we have here? Yeah, manometry findings include uncoordinated or absent peristalsis with increase in LES resting pressure. Increase in LES resting pressure is very important, because the next esophageal disorders that we are going to study, diffuse esophageal spasm and all those stuff. So there you will be asked to compare the LES resting pressure. Okay. So make sure you know LES resting pressure increase किस में होता है, normal किस में होता है, decrease किस में होता है, everything. Okay. Another thing, barium swallow shows esophagus with area of distal stenosis, bird big appearance. So this image is most common. यही image exam में भी आएगा. Okay. And in the treatment, they might give you what can you use? No, not solid first. I think liquid only. Let me just check. I think liquid, because if there is normal obstruction, then there is solid. Um, I'll check this in the surgery notes as well. Okay, I'll check this later. But I think most probably it is liquid first and then solid. Okay, so I'll check it later. Okay, for now just keep it here. But most commonly it is this. I might be mistaken. No problem. And I'll check and let you know. Okay. So in the question they might say botulinum toxin injection. Okay. So that's it for the echinacea cardia. Now one thing they will relate echinacea cardia is Chagas disease, that is caused by Trypanosoma cruzi infection. So along with in the Chagas disease, along with echinacea, there will be toxic megacolon. Okay, there will be toxic megacolon. And what is the most common symptom of cruzi infection is, it is also known as, I think, kissing disease, and it is seen in South America. Okay, so all these stuffs are important. Toxic megacolon के साथ, if they ask you what esophageal disorder, you can see here is तो echinacea cardia. Okay, all these are important. ये liquid solid का मैं देख के बता दूंगा, don't worry. Most probably I think it is liquid, because they have given here present with progressive dysphagia to solid and liquid versus obstruction जिसमें पहले solid होता है. But let's just see, no problem. And yes, it increases risk for esophageal cancer, and this echinacea is for sure going to come very important. So many times they have asked it in NBME, and you will maybe बहुत बार पूछा. That's it for echinacea. Let's move forward. Okay. So here, let's just see first the distal esophageal spasm. So formerly called diffuse esophageal spasm, spontaneous non-peristaltic contractions of esophagus with normal LES pressure. Here you need to remember normal LES pressure. In echinacea, it was increased LES pressure. Okay, increased LES pressure, whereas in the ES, you have normal LES pressure. Presence with dysphagia and angina like chest pain. Barium swallow may reveal corkscrew esophagus. This is important. Okay. Corkscrew they haven't given yet, but this is how it will happen. Corkscrew. Okay, so corkscrew is going to be present like this. So DES, we are done. After that, let's just go for eosinophilic esophagitis. Where is eosinophilic? Mm-mm. Not given here, eosinophilic. Okay, in this only they have given here. Eosinophilic esophagitis. Infiltration of eosinophils in the esophagus, often in patients with atopy. Okay, so you know atopy, you have studied that atopic dermatitis and all those stuff. So eosinophils, obviously there has to be some allergy problem. Okay, so food allergens, dysphagia, food infection, esophageal rings and linear furrows often seen. This is very important. Esophageal rings and linear furrows, very 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 important. This question was there, I think, in NBME. Linear furrows seen in eosinophilic esophagitis. Okay. Next one, esophageal perforation. Esophageal perforation. Most commonly iatrogenic following esophageal instrumentation. Non-iatrogenic causes include spontaneous rupture, foreign body ingestion, trauma, and malignancy. Okay, so if that is, they will say you post-surgical, there was bleeding from the esophagus or something like that. Okay, may present with pneumomediastinum. Subcutaneous emphysema may be due to dissecting air. Signs include crepitus in the neck region or chest wall, and the most common symptom or the syndrome that we'll be discussing here is Burhaft syndrome. Transmural, usually distal esophagus rupture due to violent retching. Violent retching, either violent vomiting, or it can be due to iatrogenic causes. Okay, so Burhaft syndrome is very important. Just remember that it is an esophageal perforation. And what else you need to remember here is that's it, nothing else. Nothing else. Okay. Now next one is esophageal strictures associated with caustic ingestion, acid reflux, and esophagitis. Okay, not very important. Can ignore this. Moving ahead, we have esophageal varices. Esophageal varices, dilated submucosal veins in the lower one third of esophagus, secondary to portal hypertension. This is very important. Dilated submucosal veins. Common in patients with cirrhosis, may be source of life-threatening hematemesis. So they will give you either diagnosis of cirrhosis or portal hypertension, and most common is esophageal varices. Okay. Next one is GERD. No, before that esophagitis. Associated with reflux, infection in immunocompromised, that is candida, white pseudomembrane. HSV1 may punched out ulcers, CMV may linear ulcers. Pill-induced esophagitis can be due to bisphosphonate, tetracycline, NSAID, iron, and potassium chloride. All of this is very important. White pseudomembrane, isma candida. Punched out ulcers, HSV1. Linear ulcers, CMV. And in the drug that they have mentioned here, bisphosphonate is very important. And while we study the pharmacology of bisphosphonate, we have studied कि 30 minutes के you should not lie down. Okay. After you consume bisphosphonate, you should not lie down till 30 minutes. Okay. So make sure you know that. Now coming to GERD, gastroesophageal reflux disease, transient decrease in LES tone. What is happening in echinacea? LES tone will be increased, I think. So here there is transient decrease in LES tone, commonly presents as heartburn, regurgitation, dysphagia, may also present as chronic cough and hoarseness. Okay, associated with asthma. Okay, all those stuff include erosive esophagitis, strictures, and Barrett esophagus. Now see what all was important over here is heartburn. Heartburn is very important. That will help you to distinguish from the different types of other esophagitis and regurgitation. And along with that, one symptom is not mentioned here. You can write down halitosis. Why halitosis? Because when there is regurgitation, the food contents might be coming towards your pharynx, and it might be touching the last end of the molar or the premolar teeth. And food contents, if they are accumulated in the teeth, it might lead to bad breath. So halitosis can also occur here, and rest all that is simple. Okay. Next one, moving down to the Plummer-Vinson syndrome, triad of dysphagia, iron deficiency anemia, and esophageal web. Increased risk of commercial carcinoma, okay, may be associated with glossitis. Okay, in the triad, glossitis is not there. Okay, this glossitis is very important. But in the triad, glossitis is not there. But you will consider glossitis also as a clinical presentation. Okay, next one is Mallory syndrome. Partial thickness, longitudinal lacerations of GE junction, GEJ. Okay, so longitudinal lacerations of GEJ must be given. Okay, confined to mucosa, submucosa due to severe vomiting. So most commonly the patient will be coming with alcoholic. Okay, alcohol use disorder. So alcoholic hai, and when that patient tries to vomit, there might be lacerations in the esophageal wall, and that is what causing Mallory syndrome. Okay, so hematemesis, abdominal back pain, usually found in patients with alcohol use disorder. Okay, so just remember all this stuff. Coming to scleroderma, esophageal involvement. Esophageal smooth muscle atrophy, decrease in LES pressure. So here you have decrease in LES pressure. In DES, LES pressure was normal. In achalasia, LES pressure was increasing. Okay, so these are the three differential diagnoses that you will be doing based on LES pressure. Okay, distal esophageal dysmotility, acid reflux dysphagia, all the symptoms are going to be similar in all these conditions. Okay, symptoms mostly similar hone hain. Just one word you need to pick it out and you need to diagnose. And this is where the problem occurs. This is where there are high chances of doing it wrong. Okay, that's it. And yeah, this is a part of Crest syndrome. So in a Crest syndrome, you have Raynaud phenomenon, you have esophageal dysmotility, you have proximal muscle involvement. So all those stuff will cover this in the musculoskeletal system. Okay, so each and every disorder here is important. Mark this page as a high yield. You should not miss any one of them. Okay, LES pressure say you can easily make out LES pressure if it is increase, decrease or normal. Normal will be in the DES, decrease will be in the scleroderma, and increase will be in achalasia. Okay, so make sure you are thorough with this. All right, Barrett esophagus. Simple one line you need to remember here. Intestinal metaplasia. Okay, so replacement of non-keratinized stratified squamous epithelium with intestinal epithelium. Okay, just this one line is important for Barrett esophagus. This image you can easily see the intestinal metaplasia has occurred. Yeah, and yeah, see the difference. Okay, and increased risk of esophageal adenocarcinoma. That's it. That's it for Barrett esophagus. Now coming over here, esophageal cancer, another very high yield, and here they won't ask you how it is occurring, how it is not occurring. They will ask you about the risk factors, and that is what going to confuse you. Okay, so let's just see what they are saying. Typically present with progressive dysphagia, first solid and then liquid, weight loss. Aggressive cause due to lack of serosa in esophageal wall. In esophagus, there is no serosa, allowing rapid extension. Poor prognosis due to advanced disease and fragmentation. Okay, this all is okay. Okay, the symptoms are going to be simple. Regurgitation, GERD, pain, and all those stuff are going to be simple. What is going to be difficult here is squamous cell carcinoma and adenocarcinoma. Squamous cell occurs in the upper two-third, adenocarcinoma in the lower one-third. More common worldwide, more common in America. Now here the risk factors are, first pick out the common one. Common one are smoking, to remove this. Next one is, rest all are different. Okay. So now one thing that they have asked again and again, they have asked about obesity Barrett esophagus. Obesity and Barrett esophagus for adenocarcinoma. And here they have asked about hot liquid and echalalia. Okay, so hot liquid may they will give you hot tea. Hot tea most commonly given. Okay, and if they want to ask another liquid, so alcohol भी हो सकता है. So these risk factors are very high. Okay, and yeah, sometimes the image is also given. Okay, in NBME they gave the image of the esophagus. There was tumor like growth. You need to figure out whether it was squamous or adenocarcinoma. How you will figure out? You will look at the location. अगर upper है so it will be squamous. अगर lower है adenocarcinoma. Okay, so all these questions they will be asked, and this is also very high yield. Focus more on risk factors. Okay, done with esophagus. Let's move to stomach. Gastritis. Acute gastritis erosions can be caused by NSAID, burns, and brain injury. Just remember this pathophysiology over here. Moving down, see in stomach, the question that they commonly like to ask is gastric adenocarcinoma and this peptic ulcer disease. Okay, gastritis के इतने सवाल नहीं आते. Okay, but still let's see. So what happened is if they want to ask you about NSAID, they won't directly say that the patient was consuming NSAID. In the question, what they will say is that the patient was of rheumatoid arthritis or any other chronic disease. Okay, they won't say that the patient was taking NSAID. Okay, you need to figure out कि अगर chronic disease है, so yes, NSAID must have been given to the patient for the pain relief and everything. You need to figure out. Okay, here also they have given, especially common among patients with alcohol use disorders and those taking daily NSAID, rheumatoid arthritis. But they won't say in the question, they won't mention in the question कि the patient was taking NSAID daily. Okay, so you need to figure it out from it. Moving to chronic gastritis, mucosal inflammation often leading to atrophy, that is hypergastrinemia is going to occur, and intestinal metaplasia that is going to increase the risk of gastric cancer. Okay, all this stuff not necessary. They will ask you the most common cause of gastritis, so your answer will be H. pylori. Okay, H. pylori, and then they will ask you which is the most common location. So antrum or duodenum. You can say first part of duodenum, either antrum of stomach or the first part of duodenum. And yeah, autoimmune autoantibodies T cell to ये autoantibodies. So autoantibodies is important, and this is because of pernicious anemia. It can result in pernicious anemia, affect body and fundus of stomach. So ज्यादा सवाल नहीं आते, but if they ask you the most common location for gastritis, either choose the antrum of stomach or you can choose the first part of duodenum. Most common cause of gastritis H. pylori, and the most common case they will give you if they want to ask about acute gastritis is the patient was on a chronic disease. They won't mention you whether he was consuming anything. You have to figure it out by yourself. Menetrier disease, never question have been asked, but you can just remember this by the protein loss in the urine. Okay, and parietal cell atrophy. That's it. So ऐसे याद कर लो. बाकी they have never asked. And one thing is hypertrophic rogue, hyperplasia of gastric mucosa. Okay, so just make sure you know. Coming to gastric cancer, very important part of stomach. Here, the most common is gastric adenocarcinoma. Now, these are the symptoms. Okay, symptoms to easy identify करना है. But coming here is lesser Trellis sign. Acanthosis nigricans or lesser Trellis sign. Can anyone tell me lesser Trellis sign में कौन सा dermatological condition is there? Yeah, Pooja, Srishti, anyone? Anyone?
Seborrheic keratosis,
Yeah.
multiple sudden onset of multiple on the back. It's there,
Yes,
the
yes,
picture.
yes.
Mm.
Seborrheic keratosis. Okay, so we will do this in the musculoskeletal system, no worries. So if lesser trellis sign is there, so they might ask you lesser trellis sign is there and what dermatological condition is actually present here. Your answer should be seborrheic keratosis. Okay, you should remember this. Now there are two types, intestinal and diffuse. See the causes of both of them. Okay, causes are important. If it is intestinal, they will be associated with H. pylori. Dietary nitrosamine, smoke food common in East Asian countries, and here they will give you the example of China and Japan. Okay, A 60-year-old patient who is a resident of China now shifted to US, and there was all this problem. They will give you a question like this. You must have seen this in the U world. Okay, so you should be knowing East Asian countries eat lot and lot of smoky food like fish, uh, tofu, and all those stuff. Okay, they are very smoky and they contain nitrosamines in them. So this is because, and that can lead to the gastric cancer. Okay, tobacco smoking and commonly on lesser curvature looks like ulcer with raised margin. So this is okay if you don't remember. Just remember the causes over here. Coming to diffuse, not associated with H. pylori. Okay, E. gathering mutation is important. Signet ring cells is important. Okay, signet ring cells. This is what the signet ring cell. Signet ring cells is seen in what other condition? Can anyone tell me? I need two conditions. Bolo bolo. Where can we see the signet ring cells? Can we see it in malaria and babesia? Agree or not? Okay. So stomach wall grossly thickened and leathery. Let me just check I am correct or not. Yeah, you can see. Okay. Signet ring cells can be seen in malaria and babesiosis also. So yeah, leathery, linitis plastica, stomach wall grossly thickened. So all these are for ring diffuse gastric cancer. Now yes, then you need to remember his lymph node names also. Okay. So if it is Krukenberg tumor, ovaries and stomach, they have asked this very important, very frequently. Virchow node, supraclavicular node, systematic Joseph node, subcutaneous periumbilical metastasis, Blummer cell in the pouch of Douglas. You need to remember the organs and you need to remember the name of the lymph node also. Okay, gastric cancer, it becomes very, very important and high yield stuff. All right, that's it. Let's move on to the peptic ulcer disease now. PUD. So peptic ulcer disease can be gastric ulcer or duodenal ulcer. Let's just look. Can be greater with meals, decreases with meals. H. pylori 70%, but 90%. Decrease in mucosal production against gastric acid, decrease in mucosal production or increased gastric acid. Okay. Other cases, NSH and JDS. Increase in biopsy margin to rule out malignancy. Generally benign, no routinely biopsy. So if they ask you peptic ulcer most commonly seen in duodenum. Okay, first point. Second point, they will give you it is after meals, like it is increasing with meals or decreasing with meals. They will give you. Okay, and that's how you will identify gastric or duodenal. Okay, this is what you need to remember over here. Now, apart from the PUD, they ask about complications also. Now, what complications they love to ask is hemorrhage. So if it is in mostly the hemorrhage are posterior one. Okay. So if the gastric ulcer is ruptured, then bleeding will be from left gastric artery. But if duodenum is ruptured, it will be from gastroduodenal artery. Please remember the name of these two arteries. That is the complication of peptic ulcer disease that might occur if there is a rupture of this ulcer. Okay. Very important questions have been asked. Now obstruction, now they have asked perforation. In duodenal, anterior perforation is more common, but bleeding is posterior. Okay, just remember, duodenum में bleeding posterior, but perforation will be in the anterior. Okay, now what happens here? Anterior duodenal ulcers can perforate into anterior abdominal cavity, potentially leading to pneumoperitoneum. And this is how pneumoperitoneum is diagnosed. You can see, if you see this structure like this, pneumoperitoneum. Okay, may see free air under diaphragm, which refer pain to the shoulder via irritation of frenulum. So this is all you need to remember. Okay. So I think we are done with stomach here. Okay, we are done with stomach. So esophagus done. In stomach, you have two conditions: PUD and gas carcinoma. In esophagus, that entire page, all the conditions are important along with the cancer. Okay, so two organs done. Let's just move to the intestine, small intestine. So small intestine has malabsorption syndrome. So if you want, just go through this for one, or else not required. Okay, just understand what they are talking about. Celiac disease is an autoimmune disease, so they have given related to all the immune factors. Just give me a minute. If you want, you can take 2 minutes break or something like that. I think we will be able to finish GIT only. The liver and that part we will do tomorrow along with the next system. Next system tomorrow we'll be doing is hematology. Okay, so we'll finish liver and all gallbladder and all those stuff. That is small system, and along with that we'll start hematology. I'll finish RBC that list. All right, let's continue. Malabsorption syndrome, and in the malabsorption syndrome, the most commonly they ask is celiac disease. Rest all they never ask. Okay, and the celiac disease is very important. Let's just write down what all is important over here. Can cause diarrhea, steatorrhea, weight loss, weakness, vitamin and mineral deficiency. Screen for fecal fat. So Sudan stain screening is very important. Okay, so in the question, if they are giving you the diagnosis of celiac disease, and so they might mention that the fat was voice is double. Now also the voice is double. Hello.
Yes.
How is that? सृष्टि आपको भी आ रही है क्या डबल?
No, it's okay for me.
या पूजा एक बार लीव करके वापस ज्वाइन करो ना, क्योंकि आई डिडंट चेंज एनीथिंग, तो शायद आपके वहाँ कुछ हो रहा होगा. ओके. Can cause diarrhea, steatorrhea, weight loss, weakness, vitamin and mineral deficiency, screen for fecal fat. So either the question will be giving you about celiac disease, and then they will ask you how it can be screened. Okay. Okay, then they will give you how it can be screened. So the answer will be Sudan stain screening. Okay, यहाँ पे you will be screening for the fat. Okay, so Sudan stain screening से आप करोगे. Now, also called gluten sensitive enteropathy. Okay, it is an autoimmune disease. Okay, intolerance of gliadin, gluten protein found in wheat, barley, and rye. Because of gliadin, it is occurring. Okay, associated with HLA, DQ2, and DQ8. This is you have to remember. Okay, you have to remember. Autoimmune, you have to remember. Gliadin, you have to remember. Primarily affect distal duodenum and proximal jejunum. So malabsorption and steatorrhea. The treatment is going to be gluten-free diet. Here also questions will be asked. You have to figure out what the question is saying. If they are saying celiac disease, and at the end they will give you what you should do now. So the answer will be gluten-free diet. Avoid, mostly they will give you uh, avoid bread and cereals. They will give you avoid bread and cereals in the options. You will have this question. Okay. So I hope this is simple. Celiac disease is the most frequently asked question. तो इसमें और कुछ भी देख लेते हैं. What else can be there? Dermatitis herpetiformis, and yeah, T cell lymphoma is also important. T cell lymphoma का युवल में ही एक question they ask. Okay. Serology. IgA positive anti tissue transglutaminase, anti-endometrial, anti-deamidated gliadin peptide antibody. So these are the name of antibodies that you need to remember. Along with that, histology, villus atrophy, crypt hyperplasia, and intraepithelial lymphocytosis. This same line will be given everywhere in UL, in NBME, everywhere. Mark my words, celiac disease is most important malabsorption syndrome, and this is the only malabsorption syndrome that they will be asking you again and again. ओके, सो इसमें एक एक वर्ड बहुत जरूरी है. इवन दिस ब्रैकेट टी सेल लिम्फोमा इज वेरी इंपॉर्टेंट. दे हैव लिंक्ड विद दिस आल्सो. ओके, so that's all for the celiac disease, and if you want you can just give it a read over here. Okay, lactose intolerance, we already did this in biochemistry, so let's just skip it. Pancreatic insufficiency due to chronic pancreatitis, cystic fibrosis causes malabsorption of fat and fat soluble vitamins A, D, E, K. Okay, decrease in duodenal bicarbonate and fecal elastase. We have already did this in cystic fibrosis. Okay, so no need to go in detail here. Tropical sprue. Similar finding that celiac sprue, but responds to antibiotics. Celiac disease won't respond to antibiotic because it's an autoimmune disease. Okay, this is one difference. Second, seen in the resident or recent visitors to tropic, mostly Caribbean. Okay, and in celiac disease, I forgot one point here. Northern European descent. Northern European descent, it can be UK or Germany or France. Okay, Northern European descent is very important. All right, so all these are very important. You need to remember, and that's it for tropical sprue. They will give you Caribbean only. Caribbean is the most frequently they will be giving you. And another difference here is can involve ileum with time, affecting duodenum and jejunum, but can involve ileum, whereas celiac disease won't involve ileum. So this is how you will be making the differences. So make sure you know. Mostly they won't ask. Okay, they won't ask tropical flu also. Coming to Whipple disease. Now one thing that you can make sure here is if there is a problem with GIT plus cardiac plus neuro, okay, and plus bone. Okay, so four systems are combined here. You can think about Whipple disease, and the organism responsible here is Tropharema whipple, intracellular gram positive. So PAS positive foamy macrophages in intestinal lamina propria. That's it. Okay, I know it's so big, but you have to remember. देखो कि GIT के साथ कार्डियक इन्वॉल्वमेंट है और न्यूरो इन्वॉल्वमेंट है और बोनी इन्वॉल्वमेंट. Most commonly they will give you the bony involvement at LGR. Okay, so PS positive is very important and foamy macrophages. They might give you this image also. See, this is very foamy. Alright, so that's all for the malabsorption syndrome. Focus more on celiac and second, Whipple disease. That's it. Now, another very important. Each and everything in GIT is very important. Even when we study surgery, GIT is very big and very important. So let's just see Crohn's disease. So before reading the information here, I will give you a quick overview. Crohn's disease और ulcerative colitis को easily differentiate कैसे कर सकते हो आप. Okay. So Crohn's disease में rectum नहीं होगा. Ulcerative में there will be rectum involvement. Another there will be skip lesion. No skip lesion. Okay. And if it is a skip lesion, how the question will be framed? Some regions of bowel appear normal, but some are damaged. Okay, so they will give you this line. So आपको ये line समझ के you should think skip lesion. Some are normal, some are affected. Normal, affected, normal, affected. Okay, so think about this. Skip lesion, rectal sparing because rectum won't be involved, and any part of GI. And ulcerative colitis, it can occur anywhere. Rectum be involved होगा. So these are the small differences you need to remember. Second, Crohn's disease is a transmural inflammation, and in Crohn's disease, you will be seeing fistula formation, whereas in ulcerative colitis, no fistula. Okay, this is another difference. Cobblestone mucosa, creeping fat, string sign on small bowel follows you. These all are important. Okay, this is how you will be able to diagnose it. Whereas in ulcerative colitis, friable mucosa with superficial or deep ulceration, loss of hosta, so here will be lead pipe and here will be string sign. Okay. Microscopic में non-caseating granulomas is very important. Crypt abscess ulcers, no granulomas. Complication, दोनों में same. Fistula, we saw intravesical fistula and another one perianal disease. Here there will be toxic megacolon. Toxic megacolon is most important. Intestinal में diarrhea may be bloody or not bloody, but in ulcerative colitis it has to be bloody. Okay. Extra intestinal में no need to focus more here. दोनों में common है. Kidney stone, calcium oxalate you need to focus. And there is one antibody over here, anti-Saccharomyces cerevisiae antibody. Whereas here there is cholangitis. Okay, sclerosing cholangitis. We'll study this in the gallbladder part. Associated with MPO, P-ANCA, C-ANCA, you need to remember. Treatment, avoid disease activities. Okay, you can avoid. Fecal calprotectin, this is the new information they have given. It can be used for screening और monitoring activities. Okay, so guys, ये part बहुत ही important है. Whether you go for step 2, step 1, your surgery, university exam or anything. Difference between Crohn and ulcerative colitis, they have always done. Okay, so just 3 to 4 things आपके tip of fingers में होने चाहिए. No rectum, skip lesion, creeping fat, cobblestone mucosa, fistula, calcium oxalate, non-caseating granuloma. That's it for Crohn. और इसके अलावा कोई इन्फॉर्मेशन आती है that will belong to ulcerative colitis. Ulcerative colitis has less information. Rectum involvement, friable mucosa, bloody diarrhea, no fistula. That's it. Done for ulcerative colitis. One important link of ulcerative colitis is toxic megacolon, and second is sclerosing cholangitis. Okay, very simple. Just give it a read again and again. So many questions are there in UL and NBME also. Okay, yeah, and in Crohn's disease, they will show you creeping fat. They will show you creeping fat. They will show you cobblestone mucosa. So whenever you are solving UL or NBME, make sure you have at least seen them for once. Okay, and friable mucosa is friable. It is like when you eat जब भी भजिए खाते हो तो वो कैसे फ्राई होके निकलता है, सेम इट इज लुकिंग लाइक दैट. Okay, this is the string sign, string of calor. Okay, so all these are small information you have to remember. If they show creeping fat, so they will show you intestine, and there they will show you the yellowish deposition. So that is a creeping fat. Cobblestone mucosa, they will give you rock like stone. And see, this is all the small things you need to remember. Okay, so again I'll mark this as very important question. बहुत आएंगे. Remove microscopic colitis, no need to do. Irritable bowel syndrome. Now, how to distinguish from the inflammatory bowel syndrome? One simple funda. If in the question they say diarrhea followed by constipation, they will definitely give you, or else they won't ask for irritable bowel syndrome. One question is there in new world for this. बाकी कहीं पे भी ये क्वेश्चन नहीं देखा है. Chronic symptoms may be diarrhea predominant, constipation predominant, or mixed. Pathophysiology is multifaceted, no need. Associated with fibromyalgia and mood disorders. So most commonly it will be seen in females after 50 years. Okay, because fibromyalgia is most commonly seen in females. Okay, no need to worry about anything. And the treatment is lifestyle modification and diet change. Okay, that's it. That's it. Let me see. I have some extra information or not. Yeah, and this recurrent abdominal pain should be at least for 3 days. And another thing, uh, normal intestinal structure. Okay, there won't be any gross morphologies like in Crohn's and ulcerative colitis. Intestinal structure normal रहेगा, so easily able to identify. Okay, coming to appendicitis, acute inflammation of appendix. This is the appendix here. Can be due to obstruction by fecally or lymphoid hyperplasia. Now, what is fecally? Stone made of feces. Stone made of feces. Okay, so fecally is important. Proximal obstruction of appendiceal lumen, closed loop obstruction, increase in interluminal pressure, stimulation of visceral afferent nerve fiber T8 to T10. This is what is responsible for the pain. Okay, so fibers at T8 to T10 diffuse periumbilical pain. This is important line in appendicitis. Pain localized to right lower quadrant, and McBurney point is important. 1/3 the distance from right, and this is important. Nausea, fever, may perforate peritonitis can occur, may elicit psoas, obturator, and rousing sign. Okay, and guarding and rebound tenderness. So instead of these signs, rousing sign की जगह they will give severe right lower quadrant pain with palpitation of left lower quadrant. So if you palpate on the left lower quadrant, आपको pain right में हो रहा है. That is rousing sign. Okay. So this is all about appendicitis treatment appendectomy. Okay, not very high yield. One or two questions are there in new world. Okay, coming to the diverticula. Diverticulum, blind pouch protruding from the alimentary tract that communicates with the lumen of gut. Most diverticula are acquired and are termed false diverticula. So they will ask you which are false diverticula and which are true diverticula, and what is the difference in them. Okay, so false diverticulum may only mucosa and submucosa, whereas true diverticulum may all gut layers. Okay, so first coming to the diverticulosis, many false diverticula of colon. Okay, तो diverticula से ये होते हैं diverticula colon के आजू बाजू there is short opening pouch, that is what diverticula. They won't ask you for this, don't worry, they won't ask you, it becomes difficult also. Okay, so moving to diverticulosis, commonly occurs in sigmoid colon, people greater than 60 years of age, interluminal pressure, focal weakness, all this stuff, associated with obesity and diet low in fiber, high in total fat and red meat. This is where you will make your diagnosis. They will give you this line. Okay, asymptomatic or associated with vague discomfort. Complications include diverticular bleeding, hematochezia, and diverticulitis. So there will be perforation. Okay. So diverticulosis. If the question comes about diverticulosis, remember 60 years. Then low fiber diets plus high in red meat. Okay. So all this is important when you are considering diverticulosis. Okay. Now moving to diverticulitis. Inflammation of diverticula with wall thickening. Left lower quadrant pain, fever, and leukocytosis. How you will distinguish between diverticulosis and diverticulitis? Diverticulitis may there will be fever, but in diverticulosis no fever. Okay. Complication abscess fistula. Here the fistula will be colovesical, whereas in Crohn's it was enterovesical. Okay. Here it is colovesical, whereas in Crohn's enterovesical. And obstruction will be perforation, white arrows, peritonitis, hematochezia, is there. Okay. So they won't ask mostly this part. They will just give you this, and you need to figure it out. Okay. So diverticulosis and diverticulitis is important. They have asked one or two questions in UL and BME. I have come across only one question, I think. Not so many questions have been asked. Okay. So UL में दिया है, so you have to figure it out. So appendicitis, diverticulosis and diverticulitis important है, कर लेना. Irritable bowel syndrome में I help you distinguish between inflammatory and this. Okay, that's it. Moving forward, Janker diverticulum, again false diverticulum. They will give you this image, easy to identifiable. They won't ask you the area. Okay, Killian triangle. They won't ask you, but symptoms you need to figure it out. Bad breath, aspiration, dysphagia. And because of this you can see the neck mass also, and it is more common in older female. Done. अगर ये आपको दिखा रहा है, straight away go for Janker diverticulum. It is a false diverticulum occurring at Killian triangle, bad breath, aspiration, dysphagia, and neck mass. Most commonly old female. That's it. Nothing else you need to remember. Coming to Meckel diverticulum, it is a true diverticulum and it is the most common asked in exam. You will definitely get Meckel diverticulum का question in exam. Definitely. Okay, U world में इतने सारे question है, NBA में भी इतने सारे है. Okay, so let's just see. What is this? Persistence of vital in omphalomescentric duct may contain ectopic acid secreting gastric mucosa or pancreatic tissue. Most common congenital anomaly of GI tract. Most common can cause hematochezia, melena, right lower quadrant pain, intersusception, volvulus, and obstruction near terminal ileum. The most common location they have asked in UL. Most common location for Meckel diverticulum, ileum. Okay, and along with that they have asked most common abnormality in children with intersusception, Meckel diverticulum. Okay, most common location, another answer, ileocecal valve. Okay, commonly present in the first 2 years of life, and diagnosis by TC Patterson scan, also called a Meckel scan. Okay, so all these lines that I have told you, very important. True Meckel, true diverticulum. So sometimes they will say, they will tell you, they won't tell you actually in the question. You will figure out it is a Meckel diverticulum, but then they will give you whether it is a true diverticulum or false diverticulum. Okay, so if it is a true diverticulum, they won't ask directly true or false. Then they will ask how to say whether it is true or false. So you will say all layers of gastrointestinal tract are present, or only submucosa and mucosa are present. They can frame the question in any way they want to. Okay, you must be thorough with everything. So Meckel diverticulum clear ho gaya. All this information pretty important. Heart sprung disease, another very high yield. It is similar to achalasia, but in achalasia it is in the upper GI tract, heart spring is in the lower GI tract. Some minute differences are there. Let's just see. Congenital megacolon characterized by lack of ganglion cells, enteric nerve plexus, Auerbach and Michener. Whereas in achalasia, it was Auerbach. Okay. Due to failure of neural crest cell migration, this is important line. Associated with loss of functions in RET, another important. Present with bullous MSS, abdominal distension, failure to pass meconium within 48 hours, chronic constipation. Now, what is meconium? Can anyone tell me what is meconium? We have discussed this in respiratory.
First stool
Yeah,
which is passed
yeah.
by
So first,
in- fit
yeah, yeah,
infant.
yeah, perfect. So failure to pass meconium within the 48 hours, 48 hours के अंदर ही नहीं हो रहा है, नहीं हो रहा. So it is a constipation, and then normal position of colon proximal to the aganglionic segment is dilated, resulting in transition zone. So in the question, they will give you dilated colon. Okay, if they are thinking about dilated colon, a small baby is given or infant is given, think about Hirschsprung disease. Then all this information you need to figure it out. You need to remember it. Okay. Increased risk with Down syndrome, explosive expulsion of feces, quad sign, empty rectum on digital exam. Okay, empty rectum. Diagnosed by absence of ganglion cells on rectal suction biopsy. In UVL, they have given one question. What direction, like in what direction biopsy should be taken? And should it be taken multiple times or single time? So answer here will be, I don't remember the answer for this direction. You can see the UL when you come across this question. Just remember, but it will be multiple. Okay, there is one question in UL. For sure, there is one question. Okay, so just go through it and let's just see now what else is remaining. Increase in acetylcholinesterase, treatment is recession, R. So all these important one line, everything is important, guys. Everything is important. GIT will focus on any information. Okay, don't worry, it is very easy to pick it out. So more and more questions you will be solving, more and more exposure you will be getting it. Simple. Okay. Mal rotation, they haven't asked many questions. So you can leave it. Intersubsection, again very important. They relate this with Meckel diverticulum. Okay, let's just see now what is there. Telescoping of proximal bowel segment into distal segment, most commonly at the ileocecal junction. This is also at the ileocecal, Meckel diverticulum also at the ileocecal. Typically seen in infants, rare in adults. Usually idiopathic, rest frequently due to an identifiable lead point. Okay, no problem. Idiopathic form is associated with recent viral infection and the most common is adenovirus. This is important. Rotavirus infection not needed. Pair patch hypertrophy may act as a lead point. Pair patch is important. In children, Meckel diverticulum and IgA vasculitis. In adults, intraluminal mass or tumor. Okay. So what it will cause? Intermittent abdominal pain, vomiting, bloody currant jelly stools, very dark stool. Okay. Physical exam, sausage shaped mass in the right abdomen. Patient may draw their legs to the chest. This is how you will identify. Patient may draw their leg to the chest. That is what intersubsection is going. Imaging, target sign. Target sign is again important. You should identify target sign. See, this is the target sign. Okay. So that's all for intersubsection. Let me see if any information is missing on. All right. Okay. So intersubsection, each and every point is important, and in exam they're definitely going to ask you. Macular diverticulum, they will link it with intersubsection. Okay. Volvulus, not frequently asked, but let's just see the sigmoid volvulus. That is coffee bean sign on X-ray. Okay. Rest all, don't worry, no need to do. No need to do. Coffee bean sign on X-ray. This is what coffee bean sign is. Okay. So just remember this, nothing else. Other intestinal disorders, and let's just see them one by one. Acute mesenteric ischemia and chronic mesenteric ischemia. Let's just do this together. So in acute mesenteric ischemia, critical blockage of intestinal blood flow, especially SMA. Okay, SMA, superior mesenteric artery. It can be anything, ischemia, embolic obstruction, thrombosis, anything. It can be anything. Small bowel necrosis, abdominal pain out of proportion. Okay, abdominal pain out of proportion. Nothing else is given to you. Okay, nothing else is given to you. That the pain is occurring after eating, pain is occurring before eating. The pain is very due to anything. No reason is given. Achanak the patient is coming to you and he is having pain. Okay, so that is what acute mesenteric ischemia. This is how the case presentation will be. And coming to chronic mesenteric ischemia, they will say Postprandial epigastric pain. It means after you eat the meal, that time you will be having this postprandial epigastric pain. Okay, so make sure you know. So how the patient will be coming to you is patient will be avoiding food and there will be lots and lots of there will be so much weight loss. Okay, so this is the another case that you will remember for chronic mesenteric ischemia. Patient will be having significant weight loss. Why? Because she is avoiding food. Because after food she is having immense pain. So chronic mesenteric ischemia में खाने के बाद and acute mesenteric ischemia में out of proportion pain is coming. Okay. Now coming to angiodysplasia. Angiodysplasia, tortuous dilation of vessels to hematochezia, bleeding along with stool. Most often found in right-sided colon, more common in older patients, confirmed by angiography associated with ESRD, that is renal disease, von Willebrand disease, and aortic stenosis. If they give you von Willebrand or aortic stenosis or renal disease, then you should think about angiodysplasia. And one line they will continuously use is tortuous dilation of vessels. Okay, not frequently asked, but if they give you tortuous dilation of vessels, think about angiodysplasia. Okay, coming to colonic ischemia. क्रैम्पी एब्डोमिनल पेन फॉलोड बाय हेमेटोचीजिया खून के साथ स्टूल after that crampy abdominal pain commonly occurs at the watershed areas splenic flexion retrosigmoid junction older adults thumbprint signs on imaging not commonly ileus intestinal hypomotility without obstruction so constipation and decrease in flutter okay associated with abdominal surgery opiates hypokalemia no transition zone on imaging treatment is simple so यहाँ पे one thing is you need to remember this how does ileus occur associated with abdominal surgery opiates and hypokalemia these are the most frequently asked questions okay and treatment will be cholinergic drug because they will increase in the motility intestinal motility okay and ileus may you need to remember meconium ileus okay meconium ileus in cystic fibrosis and just now we did Hirschsprung disease okay necrotizing enterocolitis most commonly asked question seen in premature formula fed infants formula fed infants instead of formula fed they might give you that the baby was fed cow milk okay in US it is a common culture like when the baby is fed baby is born most commonly they feed them with the cow milk okay in the U world also they have given a detailed description about the cow milk in one of the questions so if anywhere it comes premature ko ya baby ko they are feeding cow milk think about that the page that the case that the question is asking you about necrotizing enterocolitis okay so necrosis of intestinal mucosa, terminal ileum and proximal colon, which can lead to pneumatosis intestinalis. This is another word. Pneumatosis intestinalis. And important diagram is this. This radiological image is very important. Gas in abdomen. Okay. So necrotizing enterocolitis is very important, and they will give you this image, or they will give you formula fed infants. Formula fed infants. Okay. That's it. Nothing to remember in small bowel obstruction. This is a new topic they haven't included anywhere. Okay, so let's just leave it. Yeah, one thing they haven't given here and that they have included in the small bowel obstruction is addition. Okay, so additions, let's just see. Uh, Most commonly caused by intraperitoneal adhesion, fibrous band of scar tissue, tumors, and hernia. In okay, so see, adhesion says if the patient, like if the question wants to ask you about adhesions, so they will say that he was a it was a case of post surgical that the surgery was undergone and after a few days there was obstruction in small bowel. Now, how this occurs is because of adhesion, there might be formation of scar tissue. Okay, and the scar, the fibrosis has occurred so much in the intestine that it has caused obstruction, and that is what leading to small bowel obstruction. Okay, so addition they have not mentioned here, not frequently asked. One question was there in UL, and in this section you should focus on mesenteric ischemia, both acute and chronic. You should focus on ileus, and you should focus on necrotizing enterocolitis. Okay, that's it. Now moving to colonic polyp, probably the last topic for today's discussion. We have done so much today, so much to grasp. Tomorrow we'll cover the liver and the gallbladder. It is just a half an hour topic, 1 hour topic. Then we'll start with hematology. Don't worry. Okay. So colonic polyps, growth of tissues within colon, rosty characterized as flat, sessile, pedunculated. Okay. Ignore all this stuff. No need to do anything. Okay. Just remember one thing. If they are asking you about hematomatous polyps, then they don't have significant risk of transformation. No significant risk of transformation. Okay. Moving on, adenomatous and serratus. Here you have some information to remember. Neoplastic via chromosomal instability pathway in APC and KRAS. Another important thing is tubular histology has less malignant potential than villus. This is very important line, and you need to remember which is tubular and which is villus. Okay, very important. Very, I am repeating again and again. This is tubular and this is villus. So sometimes they will give you a polyp is found. They took the biopsy in the histology. They found it this or this, and then they will say, is it which one, like is it malignant or not? So you should be thorough. Tubular is more malignant than this. Okay, that's it. Moving on to the polyposis syndrome, I'll give you a highlight how you need to remember this syndrome. So if FAP is there, okay, FAP is main, and these two are talking about FAP. Okay, FAP is main, and these two are talking about FAP. So FAP, let's just do autosomal dominant, APC tumor, chromosome is 5q, and this one. Thousands of polyps arise starting after puberty. Another thing, it is 100% progression. 100% progression to the generation. It is autosomal dominant, and if you are having this, 100% it is going to pass on to your child. Okay, 100%. This is the question they have asked so many times. In UL also two questions are there, and in NBME also they have asked this question. Okay, and always involves rectum. Most commonly it will involve rectum. So in the image in the NBME there are many questions. They have shown the part of rectum and so many polyps. Even in the UL they have shown this question, so many polyps. Okay, so make sure FAP is clear, autosomal dominant, APC gene mutation, 100% progression. Now what is there in Gardner syndrome? See, they have given FAP. FAP to hona hi hai. Okay, along with that there will be a skull problem. Okay, along with that there will be skull problem, or okay, osteoma of skull or mandible. Okay, there won't be the brain problem nahi ho raha hai, the skull or the bone problem, so don't confuse this. Okay, so congenital hypertrophy of retinal pigment epithelium, supernumerary, all these are important for gardener. Moving on to turcotte, फैप और लिंच, मैलिग्नेंट सीएनएस ट्यूमर, यहाँ पे ब्रेन इन्वॉल्वमेंट है. ओके, टर्कोट, पगड़ी, टर्बन, यू कैन रिमेंबर लाइक दैट. ओके, टर्बन दे हैव गिवन. Peutz Jeghers syndrome, autosomal dominant, featuring hematomatous polyps. Okay, hematomatous, along with hyperpigmented macules on mouth, lip, hands, and genitalia. So here क्या करेंगे? In the UL, you must have seen one question. They will give you the lip, image of a lip, and on the lips, okay, on the lip they have given this pigmentation. Okay, you must have remembered this question. I have seen this so many times. So lip pe pigmentation there hai, so then they will ask you what condition is there. Okay, so Puget-Jaggers syndrome, hematomatous polyp, pigmentation on the lips, hand, genitals. Okay, juvenile polyposis syndrome, autosomal dominant in children. So you can say that the juvenile polyposis जो है ना, that is childish form of Peutz-Jeghers. ओके, मतलब जो जो आपको प्यूज जगर्स में दिख रहा है, वॉट एवर यू आर सीइंग इन प्यूज जगर्स, if it is occurring in child, it becomes juvenile polyposis syndrome. Both will be having hematomatous polyps. So going to the cancer, like increasing, sorry, chances of becoming malignancy are less. Okay, So this is all about the polyposis syndrome, and again, these all are very important and highly. All right, moving ahead. Lynch syndrome. We talked this in DNA repair. Can anyone recollect what type of repair it was? Anyone? Come on, quickly tell me. Pooja, Srishti, याद करो.
Mismatch repair.
Yes, yes, mismatch repair. Okay. So HNPCC is the another name. Autosomal dominant, mismatch repair, MLH1, MSH2, subsequent microsatellite instability. Okay. And as I told you, how the case will be present to you. Come on. कोई मुझे बता सकता है केस प्रेजेंटेशन कैसा होगा? या पूजा केस प्रेजेंटेशन.
So, mm, like a person will present with like polyp in
हिंदी में
the,
बोलो, हिंदी में बोलो
and then
चलेगा.
or एक like कोई भी relative like mother will have some other like some endometrial cancer
Yes,
or
yes. Yeah. So if you have any type, if you have colon cancer, your mother will be having endometrial, your sister or your daughter might be having ovarian, or your aunt might be having something like that. Okay. So that is what Lynch syndrome is. Coming to colorectal cancer. So now in colorectal cancer, they ask you about whether it is the right-sided colon or it is the left-sided colon. Okay, they will ask you. So let's just write it down. Left-sided or right-sided में main problem क्या आता है? पहले डिस्कस कर लेते हैं, no problem. Screening, they are not going to ask you. Just remember one thing: patients with first degree relative who has colon cancer screen at 40 age with colonoscopy. And another thing is, yeah, this is only. And after 50 years, you need to be screened. Colon cancer की screening होनी ही चाहिए. Okay. Apple core lesion seen on barium enema. Apple core lesion. CEA tumor marker good for monitoring recurrence should not be used for screening. This question has been asked in UL so many times and even in NBME. Okay. CEA tumor marker is not the diagnosis marker. It is a screening marker. It is used for monitoring, not for diagnosis. Okay. This question has been asked again and again. So make sure you know. So iron deficiency anemia in males greater than 50 years and postmenopausal female raises suspicion. Okay. Let's just see the presentation. Most commonly, it is left-sided. Okay, they have given rectosigmoid ascending and then descending. So rectosigmoid is on the left side, left lower quadrant. Now, most are asymptomatic. Right-sided के लिए cecal ascending with ocal bleeding. Left-sided के लिए hematochezia and obstruction. Okay, let's just see another condition: ascending and descending. If it is right-sided, there is going to be exophytic mass, iron deficiency anemia, and weight loss. But if it is left-sided, there will be infiltrating mass, partial obstruction, colicky pain, and hematochezia. So in short, if we say this कि अगर right-sided है तो anemia होगा, right-sided है तो weight loss होगा, and there will be exophytic mass. It won't be infiltrating. Okay. Now, if coming to left-sided, there will be blood in stool. There will be colicky pain. No anemia. Okay. So this is how you will be distinguishing right and left. Anemia dega to right. If they are giving ascending colon, so right. And sometimes they will give you that the colorectal cancer is seen in the ascending colon. What other complications can be seen? So answer will be iron deficiency anemia. Or instead of that, they will ask you what lab parameters should you go for. So you will say serum ferritin. Okay. So आपको दिमाग खोल के रखना है. Anything they can ask. All right, done with the colorectal cancer. Now coming to the last part of the today's class, molecular pathogenesis of colorectal cancer. So yeah, this diagram is very high yield. You must have seen many questions. Okay, you must have seen many questions here. Let's just see what they have given. First one, chromosomal instability pathway, microsatellite instability pathway, and overexpression of COX2 is also linked. Okay, mutations in APC cause FAP. In microsatellite ability, you going for the Lynch syndrome, and in COX2, it can be anything. Now let's see the diagram. If there is progression from normal colon to colon at rest, the problem is of epithelium. If the colon at rest is going to transform into adenoma, the problem is in graft. And if from adenoma to carcinoma it is transformed, the problem is in this gene. Now here, yeah, write down one thing they haven't given here. Here is because of loss of mutation. Here, sorry, not mutation, function. Loss of function. Here it is gain of function, and here again loss of function. Okay, see, because they already given your loss, and here they haven't given anything. So this is the question they have asked. The gain of mutation, what is that? And see, wherever you see this question, just see from what transformation to what transformation they are asking. Either they are asking from normal to adenoma, adenoma to carcinoma, normal to carcinoma, at risk to adenoma, or at risk to carcinoma. Okay, so make sure you read the question properly. All right, with this we are done with GIT. We will tomorrow we will cover the liver, gallbladder, and pancreas. This is very small, but today I am tired. So much information to grasp today, and as usual, after the class is over, give a read. Okay, so class is over. If you have any doubt in GIT regarding that achalasia, I will just confirm and inform you in the group itself. Okay, तो इसके अलावा कोई doubt है, let me know, or else you can leave, the class is over. And if Pooja and Srishti you want to have a separate meeting with me, let me know. I am okay with that also. Yeah, any doubt? Okay, Pooja ने छोड़ दिया. Srishti, any doubt? So you want to have a meeting or done?
Yeah, can we talk on WhatsApp?
Yeah, yeah. So I'll leave this. Okay, I'll call you WhatsApp पे. Okay.